vertebra will unite with the vertebral body of lower vertebra, and the intervertebral disc lies in between both. And posteriorly, the superior articular process of the inferior vertebra unites with the, or makes a joint with the inferior articular process of the superior vertebra. Okay, so these are the joints. So this is a lateral view where again you can see the.
Sorry, Madhan.
Yeah.
It seems like your slide is stuck on the first one. You haven't shared it.
Okay, fine. So I'll do a new sharing.
Yeah, do a new sharing, I think.
Can you see the slides moving now?
Yes.
Fine. Right. Right. So let me tell once again about the various bony prominences. So here in the anterior side of the vertebra, we have the vertebral body, and posteriorly we have the posterior arch. Okay, the posterior arch comprises of the pedicle posteriorly and anteriorly, and the lamina posteriorly. These lamina will unite in the center, forming the spinous process, and the transverse process will be emerging laterally, where the pedicles is ending and lamina is forming. And each vertebra will have two superior articular process and two inferior articular process. The superior articular process will unite with the inferior articular process of the superior vertebra, forming the facet joint. Okay, and the vertebral canal will be between the vertebral body and the posterior arch. So the vertebral canal contents will be lying in this area. So this is the lateral view. Here again you can see the vertebral body anteriorly, the intervertebral disc lying in between the vertebral body, and posteriorly we see two spaces. The first space is the interspinous space. This is the space in the midline between the two spinous processes. If we see the spine diagonally, you will see the space here between the two lamina, which will be the interlaminar space. So whenever we are trying a paramedian approach for a central neuraxial blockade, our needle will be entering to the interlaminar space. One more other space is the interforaminal space or intervertebral transverse space. Here the nerve roads will be emerging out. We are not bothered about this because we are not going to put our needle anyway here for a central neuraxial blockade. So here you can see the interlaminar space in this. This is the diagonal view where you can see the space between two lamina. So this is the lamina of the inferior vertebra, and it's exactly above that you can see the laminar space. Here again you can see the interlaminar space, and in the midline you can see the interspinous space. So any neuraxial blockade, if you take, either it may be a thoracic level or a lumbar level or even a cervical level, we are going to enter the vertebral canal using the interspinous space in the midline and interlaminar space using the paramedian approach. So coming to the sonanatomy of the sonanatomy of structures involved in the spine sonography. Before getting into the proper structures, we need to know the echogenicity of different structures which we will be coming across. So if you take bone, ligaments, and dura, they will reflect almost all the echoes hitting them. So they will remain as hyperechoic white structure. Okay, and the soft tissue, mainly the muscle and the fat, they will remain hypoechoic. So they will be somewhere between the white and black. So they will remain gray in color. So coming to the CSF, they will allow all the echoes to pass behind them. So they will remain anechoic. So apart from the bony structures which we have discussed, we have some ligament structures which will produce some images in the ultrasound so that we can identify what is what. So we have two complexes, mainly the anterior complex and the posterior complex. So the anterior complex is mainly lies in the anterior side of the. So this is the anterior side of the vertebra. Okay, you can see the vertebral body lying in the front. Okay, so the anterior complex will be just behind the vertebral body. So what will be lying here is the posterior longitudinal ligament and then the anterior dura. There may be a minimal space in between these two, which comprises of the anterior epidural space, but it's very thin. It may not be as spacious like a posterior epidural space. So the posterior longitudinal ligament and the anterior dura will form the anterior complex, whereas the posterior complex lies in this area. Okay, and you can clearly see superficial or the posterior most white hyperechoic line, which will comprise of the ligamentum flavum, and you can see a small space between the next hyperechoic line. This space is the epidural space, mainly the posterior epidural space, and then you see one more hyperechoic line which will be formed by the posterior dura. So the posterior complex is mainly comprising of the ligamentum flavum and posterior dura. Depending upon the space in between them, we can able to appreciate the epidural space well, mainly in the lumbar region and the thoracic region. Maybe in the cervical region, the space is very narrow. So we need to know the different named views available to identify the lumbar region as well as sacral region. So we take mainly the curvilinear probe, because in an adult patient, the structures are usually anywhere between 4 to 8 centimeters, even more than that also if the patient is obese. Okay, so if we take curvilinear probe, we can have a good penetration and we can see the deeper structures. If in case we are coming across a pediatric pediatric patient where the structures are quite superficial, you can still make use of a linear probe. This curvilinear probe is kept either horizontally, which is called the transverse view, and or it may be kept vertically at the sagittal view or the longitudinal view. So these two are the major difference between the views. So, and with slight modifications, we can see different structures. See here, we are placing the probe horizontally over the lower back, mainly in the lumbar region, right? So either our echoes may hit the spinous process, or it may hit the interspinous space. So we have two views in the transverse side. First one is the transverse spinous process view. The other one is the transverse interspinous process view. Okay. So once we see the sonography picture, I'll let you know what is the advantage of these two pictures. Then coming to the longitudinal view, again we have 3+1 view. Okay. The other view is mainly for real-time ultrasound guided neuraxial blocking. So coming to the longitudinal view or sagittal view, we can either start from midline or go laterally, or we can start laterally and come medially. If we are going to start laterally and come medially, first structure we are going to encounter is the transverse process. So which will be the paramedian sagittal transverse process view. Suppose if you move the probe medially, you will come across the facet joint or the articular process. So which will be the paramedian sagittal articular process view. Further, if you move the probe medial towards the midline, you will encounter the lamina. So that will be the paramedian sagittal laminar view. So these three are the named views. And once you reach this paramedian sagittal laminar view, you just keep the probe over the lamina and give a midline tilt, okay, which will be called as paramedian oblique midline view, midline laminar view. So in that view, you can see the intervertebral canal contents better than the laminar view. So that will give you idea about the distance between the skin and the dura, and even it will be useful for to use ultrasound in real time while doing a central neuraxial blocking. So coming to the midline sagittal view, so when you put the probe exactly over the midline, you are going to encounter the spinous process. So the spinous process will appear like this. This is a zoomed picture, so it's little blurred. So in between the spinous process will be the interspinous space. Okay. So if you move the probe from the midline laterally, you are going to encounter the lamina. So as I said earlier, the laminar view will show some of the vertebral canal contents through the interlaminar space. The interlaminar space, which we dealt a few minutes back, is going to show the vertebral canal contents. So the lamina will resemble like an horse head. Okay. So you can just correlate the laminar line resembling an horse head. So this view is also called as horse head sign view or the paramedian sagittal interlaminar view. Okay. And if you move the probe further lateral, you are going to encounter the articular process. The articular process will make continuous hyperechoic line. Okay, the continuity will be followed, and here the continuity resembles like a camel hump. So this is called as camel hump sign. Okay, and here you are not going to see anything beyond the articular process because there is no window to allow the echoes to go down. So you will get a continuous hyperechoic line. If you move further lateral, you are going to encounter the transverse processes. The transverse process will be a square type hyperechoic line and acoustic shadow underneath that. Okay, so the transverse process is not letting the echoes go beyond them. So you are getting an acoustic shadow underneath that. And in between the transverse process, you can see the soft tissue window. Okay, so this is the lumbar region. So you are going to get the psoas muscle. And in between the psoas muscle, sometimes you may even see the lumbar nerve roots, depending upon the depth you are seeing and the resolution of the ultrasound impact. So here you can you can correlate this picture resembling a trident. So this is called as trident sign. Okay? The trident sign is mainly seen in the sagittal or longitudinal, paramedial, transverse process view. So coming back to the spinous process view, the transverse one. The transverse spinous process view, you put the probe in horizontally over the vertebra, and your echoes are going to hit the spinous process. Since the spinous process reflects back all the echoes, you are not going to get any shadow. You are not going to see any structure beneath that, and you are going to get an acoustic shadow in the midline. And laterally, you can see the articular processes lying. This is, and again, if further lateral, you may see the transverse process in either side. And you can see the erector spinae muscle lying. This is the lumbar region. So the erector spinae muscle is lying. This view is mainly used for giving erector spinae plane block, where you just come over here and place your needle just above the transverse process and underneath the erector spinae muscle, and you can deposit the drug. The advantage is you can clearly identify whether the drug is spreading in the plane or it is entering the muscle. The disadvantage of this view for erector spinae plane block is you may not see the extent of the drug. If you are doing it in a conventional way, you can see how far it is spreading capillary and caudal. But in this view, you may not be able to appreciate that. Rather, you can see whether the drug is spreading inside the muscle, which is called lamination, is appearing or not. Then the second view is the transverse interspinous view. Now, if you push your probe either capillary or caudal, you are going to beam the echoes between the spinous process. That is the interspinous space. Now you get a window for the echoes to go and hit the vertebral canal contents. So, as I said earlier, you are going to come across two complexes: the anterior complex lying just posterior to the vertebral body. So here, this is the vertebral body. This is the vertebral body, and this is the anterior complex. Here you see one small hyperechoic line. It's not much appreciated in this particular picture. I'll show the next one. Here you can see a better one. So here you see the posterior complex very well. You see the hyperechoic line, and you just measure how far it is lying from the skin. Okay. So you make use of calipers and just measure. So this particular individual, it is 4.1 centimeters from the skin. So this will give almost appropriate distance to for giving the spinal anesthesia. So before getting into the assistance of ultrasound for neuraxial blockade, we can make use of ultrasound to give neuraxial blockade by two methods. One is to make it available before doing the procedure. What you do is you just mark where you are going to enter and what will be the trajectory of needle. Second one is you making use of ultrasound while doing the procedure itself, which is called the real-time ultrasound. The previous one is called scout scanning. Okay, scout scanning is nothing but you just scan the lumbar spine or the thoracic spine where you are going to do the procedure, and you just mark the needle entry point, and then the trajectory also you can identify and keep. Right. So in order to do a real-time scanning, It's almost similar to what we discussed now. But if you are planning to do a south scan and just mark where you are going to do the procedure, what you need to do is you make the patient comfortable, either sitting or lateral position. Or if you are comfortable, if the patient is comfortable, you can even make the patient prone. But I would suggest you can go with sitting or lateral position, and you start counting the vertebra. Right. Again, you place the curvilinear probe. You may start from the subgluteal cleft, and then gluteal cleft, and you start pushing the probe in the cranial direction. Okay. So once you start, you will get a straight line, which will be the sacrum. Okay. After moving above, you will get the L5 S1 interspinous space, and then further above L4-5 space. Like that, you can go carefully and mark. Suppose you want to do the neuraxial blockade in L3, L4 space, you go up to L3, L4 space, and then keep the center of the probe in the L3, L4 space. Okay, and put a horizontal line exactly in the center of the probe. Okay, this will make the first line. And now we have identified which level we need to put the needle in. Second thing is we need to know where the midline is. Okay, unless we don't know the midline, it will be difficult for us to reach the central canal or the spinal canal. So for identifying the midline, we may need to put the probe horizontally and identify the structures. So once you put the probe horizontally in the level which we marked early, we are going to see either the spinous process or the interspinous view. If the interspinous view is seen, it's well and good. I try to identify the both complexes, anterior complex and posterior complex. Once they are identified, you keep it in the center, and as I said earlier, you put a vertical line in the center of the probe. Okay, and the junction point of these two, which will be somewhere here, will be the needle entry point. Okay, and how much inclination or angulation you have given to the probe from the skin. Suppose this is the skin, and you are keeping the probe like this and giving this much tilt. So the needle entry will be similar to that. So if you are keeping it 90 degree to the skin, the needle entry should be 90 degree. If it is Keflet tilt, say maybe a 10 degree, you may need to go 10 degree Keflet from the needle entry point. So next we'll discuss about the caudal epidural space. Again, ultrasound can be used to give caudal block or simple caudal epidural block. Again, we are mainly preferring caudal epidural block in a pediatric patient for obvious reason that the blockade success is more, because the sacrococcygeal ligament is lax and you can easily penetrate them and put the drug in the epidural space. Whereas in an adult, due to the calcification of this ligament, it will be difficult for us to reach the sacral canal, and maybe we may end up in a failure. Both in adult as well as pediatric, we can make use of ultrasound to identify the structures and we can proceed with the successful blockade. So for identifying the sacral structures, we make use of linear probe, because the end of the sacrum is almost superficial. Hardly it will be 3 to 4 centimeters from the skin. It may be deeper also in very obese individual. In such a case, you may need to use curvilinear probe. Okay, and as far as the caudal block is concerned, it's better to give it in a prone position whenever possible, or else in a lateral position. So again, before getting into the block, we'll just quickly brief the anatomy of a typical sacrum. Okay, the sacrum is a fused spine, right? It consists of 5 segments. So in the midline, they will be fused together and form the midline crest. Okay, and both sides will have the foramina for the sacral nodes to emerge out. And this will be the superior articular process, which will be forming the facet joint with the L5 inferior articular process. At the end, we have a defect in the posterior arch. Okay, all the S1, 2, 3, and 4 are united in the posterior side, completing the posterior arch, whereas the S5, the posterior segment is not completely fused, and we get a defect in the posterior side, which is called the sacral hiatus, through which we can access the sacral space, sacral epidural space. And the inferior articular process of the S5 will form a bony prominence on either side. Okay, which will be called as a sacral cornu. So whenever we are giving a landmark guided sacral block or the caudal block, what we do is we just palpate bilateral posterior superior iliac spine, and you make an equilateral triangle so that the apex of the triangle will be lying in the sacral hiatus. This is the way we used to identify the structure and do the block. But whenever you are using ultrasound, we can identify the sacral hiatus easily, and as well as the sacral cornu, because these are superficial structures and you can easily see them in the ultrasound. So this will be the ultrasound picture. This is the transverse view picture. Again, similar to the lumbar region which we saw recently, we have two views. We can put the probe horizontally over the gluteal cleft and see the structures, or you can even keep it in longitudinal direction also. So here in case we have kept the probe horizontally, and once we keep it over the bony prominence, mainly the sacral cornu, you see two hyperechoic lines and the acoustic shadow beneath that, and in between is the sacral hiatus, which will be a defective, which is a defect. You can see the contents of the sacral hiatus. Right. So here you can see small hyperechoic line which will be formed by the sacrococcygeal ligament. This echogenicity of this particular ligament depends upon the calcification. Say if you see in an adult patient, you may see a bright hyperechoic line. In a pediatric patient, the echogenicity may not be much appreciated like in an adult patient. Right. So in order to achieve the caudal block, all you need to do is put your needle in, pierce this ligament, and deposit the drug above the dura. Sometimes, usually the dura ends at S2 level in an adult, or in a pediatric maybe up to S4 level. It is mandatory to aspirate and make sure that there is no CSF coming, and then you can proceed with the block. So you can make use of this view and do the block, or you can make use of the longitudinal view. If you are making use of this view, you may need to put the needle out of plane. So the probe will be lying like this, and you come out of plane and enter this ligament. Okay. In plane is not admissible because it may be difficult for us to reach. You may need to come in a more steeper angle, and unless you don't have a echogenic needle, you may not see you may not appreciate the needle better. Coming to the longitudinal view of the sacral canal. So here you place the horizontal probe longitudinally over the gluteal cleft. What you are going to see is the sacral hiatus in the midline. Okay, this is the sacral hiatus, and you see the hyperechoic sacrococcygeal ligament here. So this is the ligament. So in this view, you can make use of in plane where your needle will be coming like this, and you can enter the sacral hiatus and start depositing the drug. Okay, and this will be the S4 midline test. So this is the needling. The needle is coming in plane, and once the sacrococcygeal ligament is pierced, you aspirate and make sure there is no blood and CSF. Then you can proceed with the drug injection. Right. So I completed the basics of ultrasonography for lumbar and sacral region. I'll share my video and we can discuss some of the same things in a human individual. Dr. Athar, are you able to see my video?
Yes, I can see it, but it's not.
Yeah.
Oh, now it's
just started playing.
Yeah.
Okay. So I'll stop the video and discuss a few things, and I'll resume then and there. Right. So this is the spine phantom. I have kept the spine phantom inside a water tub, and water is a good medium for echoes to pass, so that we can see the structures clearly in the screen. So this particular model contains of the sacral vertebrae and then the lumbar vertebra L1, 2, 3, 4, and 5. Okay, and this is the interspinous space, and this will be the interlaminar space. These forms the articular processes, and laterally we have the transverse processes. Okay, and we just I said we make use of the curvilinear probe, and the curvilinear probe orientation marker can be kept cephalate or corded. It's up to the individual who is doing the scan. Okay, so once you start scanning, there are two ways of scanning. Either for the lumbar region, you can start from the T12. How to identify T12? You go laterally, identify the ribs. Okay, so count the last rib that will unite with the T12 vertebra. So you identify the T12 vertebra and then come down to L2, L3, whichever you want to do. That is one way. The other way is going from caudate to cephalate. So from going to caudate to cephalate, you keep the probe exactly over the gluteal region, just above the gluteal region in the midline. So you are going to encounter the sacrum. So the sacrum will form a continuous line. So this continuous hyperechoic line is formed by the sacrum. So as you move the probe cranially, you get one defect in the continuity, okay, or break in the continuity. This first break will be the L5S1 space unless there is any abnormal anatomy is there. And further cranial, if you go, you will get the L4, L5 interspinous space. So this will be the L4, L5 interspinous space. This is the L5 spinous process. This is the L4 spinous process. Okay. So after identifying the midline, you move the probe laterally. Okay. From midline, if you move, the first structure you are going to encounter is the lamina. So here you are seeing the lamina, which resembles like an horse head. And in between the lamina is the interlaminar space. So this is the interlaminar space. In this particular model, I have put an endotracheal tube which mimics the theca. So you can see the reflection of the endotracheal tube. Yeah. So this is the endotracheal tube. So this the superficial one will resemble the posterior complex, and the deeper one will resemble the anterior complex. Okay, just for demonstration purpose, I have put the endotracheal tube in. If you scan, you may get the posterior dura here and the anterior dura here. Okay, just for easy understanding, I have done this. So after this is the typical paramedian sagittal laminar view. One more view which I told, which will be better to see the vertebral canal contents and also helps us to do the real-time block, is the paramedian sagittal laminar oblique view or medial oblique view. Okay, where after seeing the lamina, you give a midline tilt and try to beam the echoes towards the midline. So which I am doing now, and you can see the vertebral canal contents much better than the previous view. Now we see a large window of echoes going and hitting the vertebral canal content. Here you can see the complexes very well. This is the posterior complex and this is the anterior complex. Clear? Right. So after this, you move the probe further lateral, you will encounter the articular process. So the articular process will be seen continuously like a camel hump. This is called camel hump. And further lateral, if you move, you will encounter the transverse processes. As I said earlier, the transverse process will be square or curved shape, and there will not be any ultrasonography image underneath that. It will be a shadow underneath because the echoes are reflected. Since this model doesn't have any soft tissues around it, we are seeing the shadow in between the transverse process also. If we scan the in a human volunteer, you can see the soft tissues lying over here. So next, we are going to see the caudal epidural space in the same phantom. For this particular scanning, I am making use of linear probe. So I'm going to keep the probe horizontally or transversely just above the imaginary gluteal cleft. Right. The moment I keep the probe, I encounter the sacral corner on either side and the sacral hiatus lying in between both. Okay. Since this model doesn't have a sacrococcygeal ligament, we have no hyperechoic line between these two corners. Okay, so this is the imaginary sacral hiatus, and these two are the sacral corners. Right. So if you want to do the block in this particular view, you keep the probe like this, get this image, and then introduce your needle either from the superior side or from the inferior side. So the needle will be coming all the way here, and it's an out of plane approach. Okay, so you are going to get only the some part of the needle which is underneath the probe, mainly the needle tip. Right. So the other view which I told is the longitudinal view. Again, you can keep the orientation marker either capillate or caudal, depending upon your comfort level. So the moment you keep in the midline, you see the midline crest of the S4 vertebra and then the sacral hiatus. The sacral hiatus defective in the sacral canal. This will be the S5 vertebral body. Okay, the vertebral body is the posterior side of the vertebral body. Okay, this is the posterior side of the vertebral body, and here the vertebral canal content is there for the sacroepidural space. So if you are doing the caudal block in this particular view, you can keep the probe like this and introduce the needle in plane from caudal to capillate direction, so that the needle comes all the way from here to here. And once you get the pop, or if the ligament is visible very much, once you pierce that, to make sure there is no CSF and blood, and then you can inject the drug and finish the block. So I'm going to scan this volunteer, and we are going to see the same structures which we saw in the spine phantom. So again, coming to the ergonomics, the patient can be kept sitting or lateral position, and you try to keep the ultrasound either in the front, should be in the front of the person who is doing the scan, either in the left side or the right side, whichever is comfortable for you. Right. So make use of the curvilinear probe, start from the gluteal region, and start moving the probe cranially. Here in this particular case, I am keeping the orientation marker. This is the orientation marker, this cranial. Right. So once we get the straight hyperechoic line, which is the sacrum. And as I move it little cranial, I'll get the break in the continuity. So this is the first break in the continuity, which will be the L5S1 space. And further cranial, if I move, I'll get the L4 space. Right. So once I reach the L3, L4 space, I'm keeping it in the center of the screen. Okay. So this is the center of the screen, and I'm going to get a horizontal line from the center of the probe. Okay, this will be the first line, which will be giving idea about where we are going to put the needle inside. Then the second line, mainly to identify the midline. So after identifying this first line, you rotate the probe and keep it transversely and try to get the spinous process view or interspinous view. Right. Here we are getting the interspinous view. In the midline, we are trying to see the posterior complex. This is the posterior complex. This is the posterior complex. The anterior complex is lying over here. This is the thecal content. Okay. Now you can make use of calipers and measure how far it is from the skin. This particular distance depends upon how much pressure we are putting over the soft tissue. Suppose you put maximum pressure, the structures are going to get compressed. In that case, the distance is going to be lesser than the actual one. So whenever you are doing this scan, keep the probe very gentle so that we minimize the compression of the soft tissue. Suppose if you imagine a thick pad of fat is there, say 2 to 3 centimeters, and with pressure you can reduce the thickness about maybe 1.5 or 2 centimeters, and you are going to land up with the values which is much lesser than the actual one. Okay, and of course, while doing the real-time blockade, you may get puzzled why I'm not getting the CSF. So whenever doing this, keep it gently and make use of calipers to identify the distance you need to travel. So once I identify both, I'm going to join both the lines, and then that will be the needle entry point. Okay, and how much? Here you can see the tilt of the probe. It's not perpendicular to the skin. So this will be the trajectory of your needle. Say this will be somewhere between 10 to 15 degree from the skin. So that much of cephalad angulation I need to give in order to get into the vertebral canal space. So, here again, I am scanning the posterior complex and in one level higher. In this particular level, the distance is 3.28 centimeters. You can see the posterior complex very well in this level. So the other views, the laminar view, we are going to see. The midline view we already saw in the beginning of the scanning. Once the midline is identified, you move the probe laterally to encounter the lamina. So these are the lamina. These two are the laminas. And in between the laminas, the laminar space, interlaminar space, where you see the interlaminar contents, mainly the vertebral canal contents. You see the posterior complex lying here and the anterior complex lying here. So this is the posterior complex, which will be bound with the ligament of flavum. And you can even measure the distance from this posterior complex to the skin by making use of the caliper. So again, you get the same 3.3 centimeters from skin to the posterior complex, which we got in the transverse interspinous view. So it doubles our confirmation that the distance is appropriate for reaching this posterior complex. So after that, this completes the scanning of spine for central neuraxial blockade. The remaining part is just to identify the structures for giving blocks mainly. So the lateral, if you move the probe laterally, you are going to encounter the paramedian sagittal articular process view, where the facet joint block is given. Mainly it's given for the chronic pain procedure. It's a chronic pain blockade. So if patient is having facet joint inflammation, you can make use of this view and you can give the block. So this is the paramedian sagittal articular process view. You see the camel hump sign here. So further lateral, if you move, you are going to encounter the transverse process. So this is the transverse process and the acoustic shadow underneath that. And here the another transverse process is that because of the poor contact between the probe and the skin, we are not getting a good image here. And in between the transverse process, you get the soft tissue window. The soft tissue, as far as the lumbar region is concerned, is the psoas muscle, right? And above that, the erector spinae muscle is there. So for giving erector spinae block at the lumbar region, this will be an ideal view. To get this image, bring your needle all the way down here, just above the transverse process, and start depositing the drug in the plane between the erector spinae and the transverse process. So this will be the end point of your probe position, and you can come either out of plane like this or in plane from caudal to cranial or cranial to caudal like this. So that is for the lumbar sonography is concerned. Now we are going to see the caudal region. So for this particular individual is very thin, so I'm making use of this linear probe. And first I'm starting with the transverse view. So I'm keeping the linear probe transversely just above the gluteal cleft. So the moment I keep, I encounter two bony prominence on either side. So this is the sacral column, and in between them is the sacral hiatus. So this is also called the frog eye side. Now you can see a small hyperechoic line in between the both sacral column. So this is the sacral-coccygeal ligament. So for giving a caudal block, you need to come all over here, pierce the sacro-coccygeal ligament, then deposit the drug. So this arrow mark is indicating the sacro-coccygeal ligament. So either you can come out of plane or in plane. In plane, if you are coming, you need to come more steeper, and you may not be getting a good image with the routine conventional spinal needle. You may need an echogenic needle to get a good image. So the other view which I told is the longitudinal view, where we keep the probe longitudinally at the level of gluteal cleft. Here the orientation marker is cranial. Once you keep the probe, you encounter the, if it is in midline, you encounter the S4 midline crust, okay? And you see the posterior part of the S5 vertebral body, okay? And in between them, you see the sacral hiatus. So this is the sacral hiatus. And you can refine your scanning and identify the sacro-coccygeal ligament. You see a small hyperechoic line running here. This is the sacro-coccygeal ligament. So if you are doing the block in this particular view, you can, this will be the end point of this probe, and you put the needle from chordate to cephalad. So your needle will be coming all the way from here to here, okay? And by making use of this caliper, I'm just demonstrating what will be the trajectory, okay? So this will be the trajectory of your needle, right? Hope I completed the lumbosacral ultrasonography for neuraxial blockade. I take this opportunity to thank the department, Dr. Madhanmohan sir, as well as the global anesthesia development team for making this show happen continuously without any technical glitches. And I'm willing to take any questions or queries from the audience. It will be my pleasure to answer your questions. Thank you.
Thank you very much, Dr. Madhan. Like Dr. Madhan has said, feel free to type out your questions in the chat, on the chat wall, if you have any question. I'd like just thank you again, once again. I think it was a very clear presentation. I was interested more in the sono anatomy. We are given caudal blocks and obviously the spinals as well to a lot of patients here, but we're not doing so under ultrasound guidance. And sometimes it does get a little bit difficult.
Even in our center, we very rarely make use of ultrasound for real-time block. If we encounter some difficult spine, we just do the real-time scout scanning. I'll just mark the needle entry point and the trajectory. And with that itself, almost 100% times, we are successful in establishing a block.
Yes, it's quite important, an important skill to have. There are just some patients who, for one reason or the other, you have to avoid a general anesthetic, and whether you fail 2-3 times, you insist on doing it. It's quite important that we understand. And I think the sono anatomy was quite clear.
Yes.
Thank you very much. I do have just one question though.
Yeah.
Do you ever use ultrasound guided, basically the ultrasound scan to confirm placement of a catheter, say for an epidural? And if
no, we for caudal epidural, we routinely make use of ultrasound for giving the block. We generally don't prefer catheters for the sake of infection and other things. Mainly the follow-up is also a little difficult. So we generally prefer single shot blocks. But for an adult epidural, I not make use of ultrasound to check whether the epidural space, catheter is present in the epidural space or not. But I have used for single shot intrathecal blocks.
Okay.
For catheters, I have not used. I think it may be a little difficult for us to get a good picture for the epidural catheter. It depends upon the patient individual also, but still possible. We can.
All right. No, I think that's very clear. Thanks very much. Maybe we wait a little bit for.
Yeah, sure.
question.
Yeah.
Any question, anything that you would like to ask any of our participants, feel free to raise your hand and do so. Okay, it seems like we do not have any questions. Like I said, I was interested in the sonar.
One question has come, I guess. Is it useful in unclosing spondylitis or spinal spine? Yeah, this is what I mentioned in my very first slide. In ANCSPON, there may be very bleak chances of getting a successful central neuraxial blockade if the spine is completely fused. Okay, so what the ultrasound plays a major role in ANCSPON patient is you can see whether there will be any window space or a soft tissue window so that we can put the needle inside. If you are not getting any window and you are getting the hyperechoic line all around the midline or in the paramedian views, it's better to abandon the procedure, unnecessarily pricking the patient multiple times and making a mess.
A second question in the chat, is it helpful in patients with scoliosis?
Yeah, definitely yes. In scoliotic patient, it's difficult to identify the midline. The patient is obese, the patient is thin, you can still identify the spinous processes and we can go ahead with the side which is concave towards the particular side. Okay. If the patient is obese and we are not able to identify the spinous processes, then ultrasound is going to do some magic. You can really identify the spinous processes, can get the imaginary midline, and you can identify which side is the concave, which side is the convex, and you can choose the appropriate level and the side also.
Any more questions? Okay, it seems we've exhausted the questions. So once again, thanks very much, Dr. Madhan, for your wonderful presentation. Thank you for your support. Your colleagues at Ganga, particularly Dr. Bala, who has been quite instrumental in organizing this. We also thank African Society of Regional Anesthesia, Society of Anesthesia in Zambia, and the sponsors for the bigger project, the Tropical Health Education Trust, THED, who have sponsored some of our works here. So with that, I'd like to once again thank you and to thank our participants. Thank you and goodbye.
Thank you once again to everyone who is attending this webinar, and wish to meet you in some other webinars so that we can enrich ourselves. Thank you. Have a nice day.
Thank you very much. Thank you and bye.